Welcome everybody to this EURO-NMD webinar in collaboration with the European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. We have the privilege of having with us Professor Antonio Toscano, that is very well known by all of you, I'm sure. I will give him a very short introduction today, so he's the professor of neurology at Messina University and University Hospital, and he has several skills and capacities that he known to everybody. So he has a very important distinguished role in the European Academy of Neurology as a treasurer, but also as a member of other committees, namely the education one. And he has been a great support and a pillar in the works of the European reference networks, not only the neuromuscular one, but also the rare neurological disorders. So basically, he has competences and work done all across those platforms. And we know him very well. The last time we were together, he was speaking with us about rhabdomyolysis, as many of you will remember from the last webinar. Today is going to speak about a team that is ever-changing the treatment of patients with Pompe disease. And without further ado, I would start by saying thank you very much, Professor Toscano, and I will pass on the floor to you. Thank you.
Thank you very much for this very kind invitation and presentation. And I have a very long friendship with my homonymous, Antonio Atalaia. And it's very exciting work to try to be on the service of ERN, and we hope to multiply this kind of occasion to meet. So today, and I would like also to introduce my collaborator, Dr. Porcino, who is a young collaborator already introduced in the world of neuromuscular disorders. So my role today is to have a discussion with you all about the new situation that in the last few years emerged in the Pompe disease world. You know that there are several new therapeutic aspects, and I will try to summarize the major relevant features of these new possibilities to treat patients with Pompe disease. I will concentrate on the adult patients because others will talk in other occasion about the infantile form. In our country, in our center, we usually have to deal mainly with adult patients, so I refer to them. My disclosures. So for whom who are not too much familiar with Pompe disease, I just would like to have a brief introduction, trying to explain what is this kind of pathology, which is based on an enzyme deficiency, which is acid alpha glucosidase. And this deficiency can make glycogen to be accumulated in tissues, primarily in skeletal muscle, but even in other organs or apparatuses. This is an autosomal recessive disorder. The frequency is very debated. So we use, for convention, 1 in 40,000, but we all know that this kind of estimate is changing rapidly, because there's with the new possibility to diagnose these patients, so we have different results, and there is a large variability from one state to another. And there are two main forms: the infantile form, which is usually present by the first year of life, and the late onset from 1 year to adulthood with a large range of ages. The clinical course is very different. The infantile onset once was very fatal, so the majority of patients used to die, unfortunately, by 1.5 year of life. But now with the advent of the enzyme replacement therapy, the situation has changed a lot. And now we can appreciate that this very young patient can survive. The majority of them survive, and they can develop normal motor milestones and psychological milestones. As regards as the late onset form, we have a very different clinical progression, and the prevalent phenotype is characterized by a limb girdle muscle weakness, which is accompanied in the later stages by respiratory failure. So this is the main picture of Pompe disease. And in the past, several authors were convinced that there were 3 different presentations, like limb girdle presentation, a presentation based on ischemia with the sort of number of other symptoms like myalgia, exercise intolerance, or fatigue, very often present with hypercemia, and the respiratory failure. What we have discussed in the last years is mainly the fact that respiratory failure very rarely is the presentation symptom, but is usually following the muscle weakness, the limb girdle muscle weakness. This in the past happened because likely the history of patient was not well collected, because the patient before respiratory failure already had hypercemia with some of these specific unspecific symptoms. So now we think that after muscle weakness or hypercemia with other symptoms, we will have the patient with the respiratory failure, which is the most, unfortunately, the most relevant cause of death. In the modern times, we need measures of disease severity and of the progression of the disease, because we need to check, control our patients with the Pompe disease, but also because we need some objective measures for clinical trials. And in this sense, you can appreciate in this slide a number of different scales and scores, like the world famous MRC scale, but also more recently the 6-minute walking test, the some temporized tests, like for example the one we use a little bit more than others, like GSGC, gait, stairs, chair, Gowers maneuver. The QM, quick motor function test, as QMFT, and now is a very widely used, is evaluation of 16 items. And even more recently, RPACT scale, that includes the quantification of patient ability to carry out everyday life activities. And from the specific point of view, respiratory point of view, we use spirometry to measure sitting and supine FVC, MIP, and MAP, which are a little bit less applied rather than FVC, but still very important results coming from MIP and MAP. Do we have biomarkers, valid biomarkers in Pompe disease? Unfortunately not. So in this slide, you can see some of the procedure you can apply to the patient to try to check their functional status. especially from the clinical point of view. And creatine kinase is very widely studied and widely assayed, but is not a specific biomarker for Pompe disease, unfortunately, because it's very popular, let's say, in all neuromuscular disorders. But in Pompe disease, usually, at least in adult patients, we can limit the number of the expression of the CK among 500, 1,500 units per liter, usually no more. Is sometimes more elevated in the infantile cases. And the urinary glucose tetrasaccharide intended as X4 is not used everywhere. So there is a predominance of use of this, especially in the US and in some European countries, but not all of them use it. And more recently, there is the emerging role of the muscle MRI, but even sometimes muscle ultrasound can be very useful to try to better understand what is the real situation of the muscle groups. Because sometimes, from the clinical point of view, you might miss some involvement of a specific group of muscles, and by MRI, you may evidence sort of scleroadipose infiltration of muscles, which is the start of the muscle degeneration. But we need also to manage the clinical situation of patients, and we have some specific suggestion for this. When we have to study the baseline of the clinical situation of patient, we need to apply the 6-minute walking test, the FVC, and some blood or urine biomarkers like CK and X4. But even more important, when we have to follow the patient in the years, and we suggest to look at the patient at least every 6 months, every 12 months, using the 6-minute walking test, the normal parameters for the respiration, like FVC and MIP and MEP and others, check the biomarkers, because especially after enzyme replacement therapy, there is a decrease of CK and X4, and use the muscle MRI to follow the evolution of the disorder, the muscle disorder. So having said that, the usual question is, when have we got to start the enzyme replacement therapy? This is a very crucial part of the discussion, of today's discussion, because we really need to monitor the patients to try to check as soon as possible if there are early symptoms or signs. And for example, for adolescents and adults, we have to continuously check the strength, muscle strength situation, and the possibility of respiratory failure. And of course, still looking at the transaminases or CK for enzyme, muscle enzyme aspects, or for urine, the X4. So if we have the onset following the patient, we can check, we can appreciate the emergency in terms of muscle problems. We really need to take in consideration to start the enzyme replacement therapy. And this is another very debated point. If we have a clinical decline with the first generation ERT, what are we going to do? So the general idea at the moment is to try to switch from the first generation ERT to the second generation ERT. This has to be taken in very high consideration. Whereas now in naive patients, we should consider as definitely a second generation ERT, because it has been demonstrated that the second generation ERT should be a little bit more efficient than the previous one. So we have to take some decisions. When we have a suboptimal or some responses that are showing that the muscle degeneration is increased, we should think about changing the therapeutic options, use other therapeutic options. So, for example, for late onset Pompe disease, when we see that there is a difficulty, a major difficulty in the ambulation, or a increased and progressive muscle weakness, or there is a worsening of the respiratory condition, we really need to think about changing our therapeutic strategy. And I put this note in this slide talking about secondary decline, because unfortunately, we don't have exactly a precise idea of what we have to consider secondary decline. So we can, following the patient, you can easily understand that the situation is not improving, and but you also can appreciate, unfortunately, that the situation is going worse. And at this point, we have a possible alternative way to treat patients, and you will see in the next slides. There is another important tool that we have used recently. In other words, it's very important to take into account what the patient refer in terms of subjective quality of life. And for this, there are a number of instruments that are called PROs, patient-reported outcomes, that can include a different scale and different scores that have to be filled by the patient, and that can make us more aware about what is a real improvement of the therapy, or what is the real derangement of the therapy related to the patient narration. This means that the Pompe disease a multisystemic disorder, you need to look after several aspects, and you need a multidisciplinary care team, which is composed by pediatrician or neurologist, but also by a number of important professionals like cardiologists, pulmonologists, geneticists, anesthesiologists, apart from the caregivers and the rehabilitation managers in this situation, also very important. So let's go to the crucial part of my talk, which is related mainly to the new possibility to start a different kind of therapy. And if you look at this picture, we know that the patient have improved with the enzyme replacement therapy, and now you have a new generation enzyme replacement therapies. But also we can adjunctive therapies like chaperones, or we can use a substrate reduction. And the great hope is to have, as soon as possible, a gene therapy that can solve all the problems of this kind of patients. So if you look at this cartoon, you can see that there are several aspects that have to be taken in consideration for the new generations therapy. Apart from new ERT, we hope that we may use gene therapy as soon as possible, and try to reach an enzyme stabilization using also a substrate reduction. So some of these points, like ERT, has been elucidated very recently with different kind of possibilities. Gene therapy is slightly emerging. Other kind of possibility to treat patients are still to be better understood. So what are the new possibilities? So they are related to the next generation enzyme replacement therapy, and more specifically, the major trials that have been concluded in the last 3-4 years are related to the use of aval-glucosidase alpha or CPA-glucosidase alpha plus miglustat. You will see in a moment what is the general mechanism of this kind of new therapies. So the main trials were conducted with the aval-glucosidase alpha compared to al-glucosidase alpha in the COMET trial, and CPA-glucosidase alpha plus miglustat versus al-glucosidase alpha in the Prof trial. And this is now the new challenge, to try to understand how to better apply this new knowledge about therapeutic options in Pompe disease. So here you can see that the red circles includes the terminals of the molecule that has the enzyme, the GAA enzyme, that has been enriched in mannose 6-phosphate content to be more efficient to try to deliver glycogen and to make a more efficient enzyme activity. And this was the new molecule on what was based the COMET trial, a phase 3 trial, multinational, multicenter, randomized, where there was a comparison between use of aval-glucosidase alpha and al-glucosidase alpha, the first generation ERT. And if you look at this other slide, you see that miglustat is a chaperone that can open the way to the CPA-glucosidase alpha to better enter the lysosomes. And this is a sort of summary where you can see the al-glucosidase alpha with the terminals, and the CPA-glucosidase alpha and aval-glucosidase alpha that are richer in mannose 6-phosphate content. Here you can see the first most important in the past paper done by the group of Dutch and US authors with others, and they studied a number of 90 patients, 60 treated and 30 untreated, treated only with placebo. And the primary endpoint was the distance walked with 6-minute walking test and the percentage of the forced divider capacity. And when you look at this, let's say now historical aspects, but historical means 2004. In fact, this therapy started in 2006. And you see that in the picture on the regarding the FVC on the right hand side, there is an improvement and stabilization of pulmonary function, whereas on the other side on the left, there is an improvement of 6-minute walking test after using al-glucosidase alpha. This was a very important trial that opened the way to the treatment of infantile and adult cases of Pompe disease. After a number of years with Benedict Schoes and other collaborators, we studied the effect of the al-glucosidase alpha after several years, and what we found was that there was a defined honeymoon with the therapy that was 2-3 years, in some cases even 5 years. And after that, there is a continuous small decline of the efficiency of this kind of therapy. So that's why the request to look for other more efficient enzyme replacement therapies. And this was the one done by the trial, the COMET trial, 109 LOPD patients. And the primary outcome measure was the change from baseline to the 49 weeks in FVC. And this was demonstrated because it was demonstrated that there was a non-inferiority of alglucosidase alpha compared to alglucosidase alpha. And if you look at this graphs, you will see that on the left-hand side, you see that there is an improvement of the FVC, which is around 3% in patients treated with alglucosidase alpha compared to alglucosidase alpha. If you look at the 6-minute walking test graph, you see that there were 32 meters more than patients with alglucosidase alpha. So this means that although these results were limited, but definitely there was an improvement using the alglucosidase alpha in terms of responses from the patients treated. This was also studied from different point of views, like especially comparing what the patient referred to us, and you see here in this graph all the patients that switched from one
Can you hear me, Antonio?
Yes.
I'm afraid that you have to restart from the alpha glucosidase alpha slide, and because something crashed, and then we'll edit the video.
Okay. So this, sorry for this. So let's see.
It's technology, don't worry.
No problem for me to restart.
Yes, this slide, yes.
Okay. So I was just saying that we also did some additional study about the results of after 49 weeks. And you can see that according to the patient responses, there was a clear improvement after the use of alglucosidase alpha rather than alglucosidase alpha in all the activities that have been reported here. And if you summarize in terms of daily activities, disease-related symptoms, ability to breathe and mobility, you see that the blue column shows that there was an improvement in patients using alglucosidase alpha. But after 97 weeks, there was still the improvement and a sort of stabilization. If you look at this complex picture, you see that starting from the New England paper, where there were FVC 3.4% better, 6 minutes to 28 meters. If If you look at the first result, about 3% in FVC in Comet and 32 meters in Comet. In the extension, you see that there is a little reduction of the FVC result in terms of 2.65 and about 19 meters, which is the result of 6-minute walking test. And after 97 weeks, and if you further consider the results at 145 weeks still on aval glucosidase alpha, you can see that the patients are quite stable at 145 weeks. Here you can appreciate the FVC is still 1.4% more, and quite surprisingly, if you look at the 6-minute walking test, is respect to 97 weeks result is a little bit more efficient in terms of nearly 21 meters at 145 weeks. So we can say, trying to summarize the effects of the aval glucosidase alpha, there was an improvement followed by stabilization in respiratory function, motor function, muscle strength, and the different patient-reported outcomes. There was also a patient that switched from L-glucosidase alpha to aval glucosidase alpha, had a slightly improved or maintained stability. There were no problems with the immunogenicity of this molecule. It was very safe. So this means that globally, considering all the results in different aspects, this is a clinically meaningful product that should be definitely applied to, especially to naive patients now, and we have to consider to switch in patients where there is a sort of decline. Let's see what happened with the other molecule, glucosidase plus miglustat. This was another important trial, and with a very high number of patients enrolled, 125. And the primary endpoint was to change from baseline to week 52 in 6-minute walking test. Unfortunately, the principal outcome was not reached, but all during the trial, there was a clear trend of improvement rather than with the CIPA plus miglustat compared to L-glucosidase alpha patient treated, although it was not statistically significant. And now, in the extension of this trial, the so-called Proper trial at 104 weeks, you can see that there is a slight improvement comparing to the initial result at 52 weeks of the 6-minute walking test, as well as a little improvement with the stabilization of the FVC results. So, in other words, we can also conclude here that the CIPA plus miglustat that has been followed for over now 104 weeks showed overall maintained improvements in terms of 6-minute walking test biomarkers or stabilization in terms of FVC, and it was also well tolerated. And now it's going to be, has been approved in several nations, as well as the aval glucosidase alpha, and other nations are going to approve it. But let's discuss even in a future perspective for a while. So we need to know the difference between when you apply ERT or you have the opportunity to use gene therapy. So ERT, of course, is something that you have to renew. The administration of ERT is continuous, and you have to do this at least at the moment every 15 days for patients, even more frequently for infantile forms. On the other end, if you look at the gene therapy, is a one shot, one time delivery when it will be possible. So on this purpose, I would show you that is a not particularly recent, about 2 years ago, there is a number of different possibility to start to have a gene therapy. Several industries are going to try to obtain gene therapy. Very recently, in the last World Symposium for Lysosomal Disorders, there was the presentation of one of the first gene therapy possibility with a trial applied. This trial is called Fortis. This was applied to 4 patients. It seems that so far the results are quite safe. We don't know exactly the functional results because it's still going. We know that 3 out of 4 the patients treated so far have left the ERT treatment. But it's very early to consider the final results of this situation. I just wanted to mention to you. And now I would like to finish with a sort of case index. This is a clinical case we had some years ago. We started to see this girl when she was 2 years old, and non-consanguineous parents, no family history for neuromuscular disorders, normal milestones. But when she had 1 year, she had a sort of laryngeal inflammation, and because of this, she had to have a blood examination, and there was a little bit elevated CK value, 500 something. This was repeated, and still, when a few months later, she had 600 units per liter. And when we examined her, the neurological examination was normal, as well as the heart and respiratory evaluation. But still, the CK was a little bit higher. We decided to perform the dried blood spot, and this was surprisingly very low. They showed a very low result in terms of alpha glucosidase, GAA activity. So following this, we decided to follow very strictly this girl, and you know that this is the potential possibility to study her. And we did practically all these examinations, either muscle MRI, muscle biopsy, on what we performed biochemical studies, and finally the genetic testing. This was the aspect of the muscle MRI that was normal. And this was the muscle biopsy, which is not normal at all. 25% of muscle cells were affected. There was a vacuolation in about 25% of them, and the evacuation was filled with glycogen. This is even easy to see when you look at the acid phosphatase stain. And the biochemical studies revealed that there was only the 3% of residual activity in muscle, in the muscle we examined, but also fibroblast and myoblast showed very low percentage of persistence of GA activity. And finally, the molecular genetic testing showed that there were 2 known mutations that confirmed the diagnosis of the little girl. So we followed hair for several years when she was 2 and 3 years, and the CK is still a little bit higher, but clinical and radiological features were normal. So this is a sort of I would like to provoke your reaction, if possible. Think about this. At this point, were you able to start treatment? So send me some responses by the chat, and I will continue to tell you the story. I would like firstly to remember that the recommendation of the consortium for the European Consortium of Pompe disease that outlined in the recommendation that the patient should be symptomatic to start therapy. So I don't know what you had in mind, but in this case, we decided not to start the therapy, but we continued.
So I started the poll.
Aha, very good. Let's see what will happen.
Half of the attendants have answered. So I'm going to show the results now.
Very good, very good. Very understandable. And we also had the same ideas to start, not to start, and then we were quite aligned with the EPOC recommendation for several years. And to raise from the floor.
Sorry, Antonio. Can you go back to your previous slide? We had another freezing. Sorry.
Sure. So I was telling that your responses are up enough, and I can understand exactly what you had in mind, because also for us, there was the temptation to start the therapy at that time, but according to the EPOC recommendation, we continued to follow her. And when she was 7 years, there was a little bit of a changing, clinically speaking. There was a scapular winging and a positive Gowers maneuver. But MRI was unchanged. So here, the little girl, you can appreciate the scapular winging. And the Gowers time was 2.8 seconds. Still a little bit higher CK, but no problems with heart or respiration. Again, so we re-examined every year her. And when she was 7 years old, still we had the clinical aspect. The clinical aspect that worsened was the Gowers maneuver, and we decided to start the therapy. So just 6 months later, the 6-minute walking test was a little bit under the normal values, improved, and she was also she showed also a decrease of CK, and the Gowers time from 2.8 seconds was 1.8, and you can see here she's 12. Yes, I would say that we were right. We had the early diagnosis, which is highly recommended in this specific field, and also a timely treatment. I would say that so far now she's 13, and she's still maintaining the very good clinical situation, and we are quite happy. And the basic discussion is this is a good example of early diagnosis and appropriate start of treatment. Of course, this was alglucosidase alpha. In conclusion, we can say that patients with Pompe disease have to be diagnosed as early as possible because we have a different possibility of starting therapy. So usually the late onset form is characterized by limb-girdle muscle weakness followed by respiratory insufficiency. We have seen that CK usually between 500 and 1,500. Honestly, no more than this. And when we have the opportunity to have an early diagnosis, now we have the opportunity to choose even. We will have in a few months the opportunity to use a different kind of therapies. And we need to consider this especially for naive patients. And we have we are studying a new recommendation that should be published quite soon. I suppose that before summer we will have some recommendation where we have to consider the possibility to include in the diagnosis decisional tree also the MRI, because it's useless to apply the therapy when you have already a muscle degenerated. MRI could be a very good tool to intercept earlier the muscle degeneration and to start therapy. And we also have to be more precise about the switching in these therapies, in these patients, because when we have the clear idea that the patient is going worse, we have to consider to switch to another kind of therapy to improve or at least stabilize the situation. So I have finished. Thanks for all the participants, and I'll be very happy to take your questions. And I would like to thank again Antonio Atalaya for this very kind collaboration.
It is me and the EURO-NMD network that thanks you, on the contrary. Thank you very much, and namely for ending with this very nice view of Messina, which is quite inviting.
Yes,
at the moment, we don't have any written answers in Q&A, but they will arrive, as you know, from our previous experience. So I'm going to start as usual. And so in this case, you've quite talked a bit about gene therapy and the hopes that we have, probably namely for the younger patients like the one you've just shown, in trying to revert the problem and avoid the burden of frequent treatment for patients, namely when they are young. The other thing that I would also consider is the fact that basically enzyme replacement therapy has a dark side in the sense that is ecologically a very burdensome treatment. So producing those enzymes are something of a very cumbersome task and with some ecological footprint. So my question is, what and when do you think we will have the possibility for at least some cases to switch from ERT to gene therapy? And do you anticipate that we'll have the same picture that we have now for SMA of finding a new type or of new variants of Pompe disease in the future as well?
Yes, this is a very important question, and we all would like to know the precise response. I don't have it at the moment, but it's very encouraging that the first results for the gene therapy appeared. This means that it's a possible way. Unfortunately, what happened in the last 5 years was that some of the proposed gene therapy disappeared, and this also was because of the cost of these experiments that were not sustainable always. But at the moment, I would say that very, very personal opinion. I think that we are going on with the ERT at least for 3, 4 years more, might be 5. But I suppose that this is the right time to expect the possibility to apply gene therapy.
Yes.
So I see that, Antonio, I don't know if you see, but I see some questions.
Yes. Now the questions have been popping out.
Right.
And I would start by the easier one for you. When would you consider stopping ERT?
Well, I mean, there are some recommendations from the epoch that we left the same also in the new version, that are mainly when the patient doesn't want, that refuse to follow the therapy because for several reasons, because he doesn't want to, he or her does not want to go back to the hospital, and because this is a big problem, especially in specific areas that are particularly mountainous or other or similar. To get to the hospital is difficult, and needs a lot of time, a lot of money to go up and down every 15 days. Other kind of possibility to stop the therapy, for example, when there is a major, another major disease or disorder that makes the Pompe disease less relevant for the patient and family. So we can also have the opportunity to decide when the patient is not responding to the therapy to stop it, which is very difficult because I personally think that if there is still muscle activity, you have to somehow preserve it. But now we have this opportunity. We can change the therapy and look at the results. So this is a very important option that we didn't have in the past.
True. And we have now two questions that I'm going to combine because they are basically addressing the same problem. So Aranut Solaim is asking if someone has breathing difficulties and muscle degeneration in MRI, if there is benefit in starting ERT. And the other question is if you have the genetic diagnosis and an elevation of CK, is it useful to start? So basically, not exactly full clinical presentations, but subclinical to early presentations. What is your opinion regarding those?
I can tell you my opinion. In the last few years, I really pushed to take in consideration the science and the MRI results, because my firm idea is that it's useless to start therapy when the majority of muscle groups are already degenerated.
Mm. I'm afraid your internet connection has been has dropped or became frozen again. Well, In this case, I'm going to finish the webinar and thank Professor Toscano and every attendant for their presence. And I would appreciate if you could give us feedback regarding this webinar, and we'll be soon in contact to continue our series of webinars. Sorry, I had to interrupt Professor Toscano because of the freezing.
I was just saying that if there is only a CK elevation and there is no clinical signs or no MRI degeneration visible, I would wait for the start of therapy. In other cases, what happened was that patients with a very minimal clinical involvement had some areas, muscle area, already degenerated at the MRI. And in that case, although there is no overt clinical signs, I would start therapy, definitely.
So I'm now giving the floor to a young person in the audience that is going to put you a question.
Bravo.
Okay.
Yeah, very good. Thank you, Antonio. I want to know if there is any face-to-face direct comparison of alglucosidase alpha with cheap alglucosidase with Vigrustat. And I saw a couple of abstracts giving indirect comparison. So what do you think?
Yes, I mean, this is a very delicate point because I have heard in some meetings that patients started alglucosidase alpha after alglucosidase alpha, and in a very short time, let's say 6 months, they changed again to CPAP. I think this is not a very correct way to proceed. We are recommending that we have to at least to wait 12 months to see what are the real benefit of the new therapy. And we don't have a specific, apart from the trials where there was the addition of alglucosidase alpha, CPAP, to the previous use of alglucosidase alpha, we don't have a large trial, which is, by the way, understandable. We don't have direct trials with CPAP versus alglucosidase alpha. And I don't think we will have.
Wishful thinking.
Thank you to all, and thank you to our audience. Please leave your feedback if you can after this, the end of the webinar. And thank you, Antonio Toscano, again for your kind intervention and your very good, as usual, delivery. Thank you very much, and we'll talk soon, I'm sure.
Thank you to you all.
Bye-bye. Bye.